All right, you can go ahead and start.
Okay. Hi there. My name is Meryl Perlman. I'm a pediatric gastroenterologist at Washington University School of Medicine at St. Louis Children's Hospital. And today I will be talking about back to school belly aches, specifically for kids who are generally well otherwise, and when it's time to go back to school, start complaining of abdominal pain. I have no disclosures and no conflicts of interest. I will say that I was a primary care physician in Chicago for about 10 years. And so I'm familiar with all of the things that the primary care physician is charged with. And so my hope was to give some simple tips and an algorithm to help walk through this very common problem. So what I'll do is, my hope is to review a general approach to children with new onset abdominal pain, which happens at the start of the school year. Go through an algorithm that I made and that I use for evaluating school-related abdominal pain, review in detail signs and treatments for school-related abdominal pain, and then re-review that algorithm again. So I wanted to start by talking about the fact that I think you'll notice that the threshold for evaluating for abdominal pain is much lower than it used to be. I think previously we attributed a lot of abdominal pain related to school as jitters or butterflies in the stomach. But really, these things should resolve within 2 weeks of going back to school, sort of the jitters and sort of the minimal stomach irritation that comes with just the newness and excitement and everything else that goes with the new school year. Um, and so if those symptoms persist longer than 2 weeks, we really need to think more about them. Um, so there's a couple of reasons why I think the threshold has become much lower for evaluating abdominal pain in kids and not just attributing it to jitters, nervous stomach, etc. This is the rising incidence and prevalence of pediatric GI disorders, recognition of the bidirectional nature of the gut-brain axis, and then just understanding and recognition that kids are distractible from their pain as are adults. Um, so in terms of the increasing prevalence of organic GI diseases in children, the incidence and prevalence are rising considerably, especially in the last decade. Um, so in particular, IBD, celiac disease, and EOE. So for inflammatory bowel disease, especially in the last 5 years, the prevalence has increased in the US by 130%. Um, and we can say in the last 10 years that there's a prevalence of about 0.2 to 2% in the US. So that's quite high. For celiac disease, there's about a 1 in 80 to 1 in 300 prevalence in US, Europe, and Australia. That's for adults and children. But we know that the incidence is rising more steeply in children. For EOE, there's a worldwide prevalence of 0.05 to 1%, and that is for all comers, so adults and children. So there's more of a reason to be aware and evaluate for abdominal pain because we have more incidence of these diseases to evaluate for. So the second reason I think is that the second reason that we need to take these complaints and these back to school belly aches more seriously is that in 1977 we really started talking about the biopsychosocial model of disease, and so this is George Engel, a psychiatrist from New York, who really introduced us to the biopsychosocial model of disease, where we recognize that the social environment, the psychological state, all sorts of outside influences impact the biology and the health of the individual. And so we've always been sort of thinking about abdominal pain in this top-down approach in the sense that school, if school is stressful, there's stressful events in the environment, then your stomach is going to hurt. And so if kids were nervous about school, we would say, oh, it's a nervous stomach. But what we're recognizing more recently, and especially as we learn more and more about the microbiome, is that the gut-brain axis is definitely bidirectional. And so we have stress and neurotransmitter effects, endocrine effects on the GI tract, but the health of the gut and the microbiome also impacts the brain. And so even though a child might be stressed about going to school and that could be giving them butterflies or jitters, if they have an unhealthy GI tract from IBD, celiac disease, eosinophilic esophagitis, that impacts the barrier integrity of the GI tract. It impacts the microbiome. It impacts neuropeptides in the GI tract, and therefore impacts stimulation of the brain and can therefore cause the anxiety or the depression or the nervousness that we're seeing. So it's not necessarily going just in one direction. I think the third reason that we need to take these really seriously as well is that, previously we would look at the pattern or the timing of abdominal pain and say, oh, if a child typically has stomach aches on school days, but they're fine on the weekend, then it must be related to school. And I think what we've come to realize is that the stress of school and all that's involved with that exacerbates organic etiologies of pain, but also that kids are distractible. And so they might have pain on the weekends too, but they're thinking about it less when they're doing things that they enjoy, like playing soccer or spending time with their friends or family. So I put together this algorithm that I hope will be helpful. And this is how, when I sort of thought through and put down on paper how I would approach a child, a generally healthy child who comes in without a history of abdominal pain or much abdominal pain or any sort of GI diagnosis, who comes in to see me because they've had some abdominal pain for more than 2 weeks that started at the time that school started. And so start at the top. And the first thing that, of course, we want to know is, are there any alarm signs? So alarm signs for me would be blood in the stool, hematochezia, dysphagia, specifically difficulty swallowing solids. So if food is feeling like it's getting stuck at all. If there's weight loss, a decreased height velocity, or the child is having to wake up overnight to have bowel movements, those are indications to be referred to a gastroenterologist. Those are all signs that cannot be attributed to psychosocial stress. If those are not happening, then we go over to this purple box on the top and get some history about some of the causes of abdominal pain that I see that can be related to the start of school. So the first one would be constipation, lactose intolerance, juice or artificial sweetener intolerance, lack of sleep, early wakenings, allergies, eating disorders, and bullying. And so I wanted to take some time to go through these 7 things that can be causes of abdominal pain in children when they start school specifically, and can be pretty easily treated, and also go through, of course, how I would suggest managing them. So the first one is constipation. So constipation is so common, of course, and constipation tends to be associated with the start of school, and there's a lot of reasons for that. You guys probably know better than I do, but kids don't like going to the bathroom in public. They don't have time to go to the bathroom. They're leaving the house quickly in the morning. And then in particular, in light of COVID, there's all these limitations on bathroom use. So there has to be only one kid in the bathroom at a time. They have to ask the teacher. They have to wait. So there tends to be, the propensity to withhold and have constipation is certainly there. excuse me, as we know, as you hold stool, it gets dry, and then it's painful to have the bowel movement. Kids tend to hold it more than it, therefore it gets, the stool ball in the rectum gets larger, the rectum gets stretched, it doesn't work as well. They also can't feel when they have to go as well. And so the stool starts to leak out. So clues to when this could be the cause of the abdominal pain are pain in the left lower quadrant, straining to have a bowel movement, streaks in underwear accidents are the key. So a kid who was previously completely potty trained and starts having streaks in their underwear or accidents at school, I would say there's a 99% chance that they're constipated. Um, other clues include multiple small stools every day, huge stools every few days, or spending a lot of time in the bathroom. For the management, I think we've all gotten really good about giving Miralax for stool softening, but I would encourage, in particular, if there's streaks or encopresis, using some sort of a stimulant laxative as well. Because if you just use Miralax, then the stool gets soft and it comes out around the hard stool and you get the leaking and the encopresis. So you really need both the combination of the stool softening and the laxative. I think as pediatricians, we're generally, less is more, but Senna is quite safe, and an easy way for a child to get some Senna is to use the chocolate X-Lax squares, which I use quite a bit. So of course it depends on the child, but for a school-aged child, 5, 6, 7, half a cap of Miralax daily and half a chocolate X-Lax square until they're having soft bowel movements daily is a reasonable starting point, which can be titrated up or down. The other thing I always suggest is that families try giving the dose after school or in the evening so that there aren't accidents at school, and or they can try them on the weekend when the child is at home. But constipation is really one to think about, certainly with this transition back to school. So the second one, which we see quite a lot of, is lactose intolerance. So we typically become lactose intolerant as we get older. So 65% of adults lose the ability to fully digest the sugar in milk, which is lactose, in adulthood. This is quite a bit more prevalent in East Asian and African American people. People of those descents. The prevalence is actually 75 to 95%. So it's something really to think about. And this is something that I think about a lot in teenagers, although I've seen it as young as age 3, 4. Excuse me. I know. So why does lactose intolerance show up when kids are going back to school? Well, first of all, they're eating breakfast again, which they may not have been on vacation. Oftentimes that's cereal with milk. And then, of course, milk is often given out at school in terms of snacks or at lunch. Clues to lactose intolerance are going to be abdominal pain after lunch or breakfast, gassiness, bloating, diarrhea, and abdominal pain. So if you are suspicious of lactose intolerance, there's really 3 ways to assess it. There's complete avoidance of all dairy for 2 weeks, and that means even dairy that's baked into cookies and bread. There's a lactose breath test, which we can do in the hospital as an outpatient, which is about a 3-hour test where we administer some lactose. The patient drinks it, and every 30 minutes they breathe into a bag, and the hydrogen that they produce in their breath is collected. And the way that works is that if the lactose is not absorbed in the small intestine where it should be, where lactase is produced, then bacteria, when the undigested lactose gets to the colon, bacteria that are in the colon ferment that sugar and produce hydrogen. And so you see a bump in the amount of hydrogen produced if the lactose is not being absorbed. And then the third way is when we do an endoscopy, an upper endoscopy, we can take a biopsy and send it to a lab that evaluates disaccharidases. So it actually looks to see if the enzyme lactase is being produced by that biopsy specimen. So those are the three ways to assess for lactose intolerance. In general, clinically, again, 2 weeks of complete dairy avoidance, as hard as that can be for some, and that means no lactate products, absolutely no dairy. Um, can really tell you whether this is lactose intolerance or not. This does not mean if a kiddo gets better after 2 weeks of being completely dairy free, it doesn't necessarily mean that they can't go back to having dairy or using lactate in the future. But that 2 week period really allows us to diagnose what's going on. So typically, what I would do is after 2 weeks, see if they've improved considerably, and then have them incrementally increase the amount of dairy that they're having in their diet, making sure that they take 1 or 2 lactate tablets before taking pizza or ice cream or something with a lot of dairy, and then figure out how much their body is able to tolerate. One caveat to this is that if kids are improved on this completely lactose-free diet, but not completely resolved, if their symptoms are not completely resolved, then they should be sent to a gastroenterologist because the lactose deficiency may not be primary, it might be secondary to an underlying cause like celiac disease or inflammatory bowel disease. This is the handout that we use, which describes foods that are lower in lactose, which might be helpful for people when they're avoiding lactose because it is sneaks into lots of things, including lunch meats, popsicles, various other commercially produced products. So something that might be helpful. So the third back to school cause of abdominal pain that I wanted to mention is similar to lactose in the sense that the symptoms, lactose intolerance, the symptoms are similar, and that is fructose or artificial sweetener intolerance. So it's, as kids go back to school, they're in different settings, they're at daycare, they're at school, they're getting snacks, they're with babysitters. And so their diet may change from the perspective that they're getting juice, which they may not have gotten at home. They also might have access to sugar-free items, such as sugar-free gums, low-sugar energy drinks at sports, snacks and lunch that have popsicles, Crystal Light. There's a number of products that say that they are no sugar added. For example, the popsicle ad that I have here, no sugar added. When I see that, to me, it suggests that there isn't any cane sugar added. But what it really means here is that sorbitol is in it, and sorbitol is one of the major contributors to the popsicle itself. And so these artificial sweeteners act as an osmotic laxative and can cause a lot of abdominal pain, bloating, gassiness, diarrhea. And so I always encourage people, if they're having those symptoms, to take a look for these hidden artificial sweeteners, especially in G2. So the Gatorade G2, the low sugar, has that. And to also stop juices at the same time and see if their symptoms get better. And I would usually do that for the 2 week trial as well. So another thing to consider when a child comes in and has abdominal pain that's starting with the start of school is changes in their sleep. So we all know that teenagers really are not designed to get up early for school. They're on a little bit of a different clock. And so, especially after being out of school with COVID and after the summer, they might not be getting enough sleep and their schedule might be shifting. They're having to wake up early to catch the bus. They're staying up late and getting up early. And this can really cause a lot of GI distress. Your stomach definitely can feel that. So clues to this being the cause would be a child who likes to stay up really late and now is having to get up very early, or feelings of dizziness, nausea in the morning, or can't or won't eat before noon. Those are Those are indicators that perhaps the sleep is what's contributing. Things that you could do about this would be to have consistent sleep and wake times, which is much easier said than done, of course. Um, Encouraging them to wake up about 30 minutes earlier so they're not having to just get up quickly. Their body has some time to adjust. Physically, not jumping out of bed. That jumping out of bed shifts blood pressure and heart rate and can really contribute to nausea. Um, and sometimes just having a glass of water by the bed and drinking that as they're waking up slowly can really help with the GI symptoms. So another cause is our allergies. Um, just briefly, in the fall, we have increase in ragweed and other allergens such as mold and dust mites and things that might be cleaners in the school, things like that. And swallowing that congestion, the mucus can be very nauseating and give a stomach ache. So clues to this as a cause would be stuffy nose, history of environmental allergies, and of course, antihistamines would be the first line for this, and if necessary, allergy testing. Another cause of abdominal pain in the transition back to school, which of course we all keep in mind, is our disordered eating. So COVID has been a breeding ground for eating disorders, amongst other things. But kids, especially preteens and teens who go back to school, they notice that their body's changing. They're conscious of themselves. They compare themselves to their classmates, and this can lead to restriction. And restrictive eating can lead to physical pain through a couple of mechanisms. So one is just being hungry, but also not when you don't eat or you're restricting your eating, you develop gastroparesis. And so your GI tract slows down, which then leads to secondary pain. We also always think about if there's a lot of weight loss associated with this, a superior mesenteric artery compression syndrome, where the fat pad between the superior mesenteric artery and the duodenum diminishes because of the weight loss, and then that superior mesenteric artery compresses on the small intestine, which causes vomiting and discomfort with eating. And so that's something to think about. So clues to disordered eating being the cause include talking about or focusing on body size, restricting eating, cutting out entire food groups, and missing meals due to stomach aches. Management, again, another thing that's easier to talk about and not to do, but reassurance of body image, positive reinforcement of body as functioning as a machine and doing what it needs to do, and then considering mental health referrals. And again, easier said than done because we know that our resources are so limited in terms of those providers. Um, so finally, and I just wanted to mention bullying. We know that bullying is a major contributor to stress in children. Um, it can cause them to become withdrawn, but it also may literally keep them from going to the lunchroom because they don't want to be in the lunchroom with the bully. So they may not want to sit at the lunch table. They may be hungry due to missed meals, um, and then have that same gastroparesis we talked about with the patients who are restricting food, or just being hungry, causing abdominal pain. So clues to this might be that they're not eating lunch, they're not participating in their usual activities, trouble focusing, poor sleep, not wanting to go to school. And I think the way to assess this would be to talk with them, ask them open-ended questions about who they played with at recess, who did they sit with at lunchtime, what did they eat for lunch, is there anybody at school they don't particularly like, and have a low threshold for the parents to talk with the teacher, to, of course, offer them a lot of support and positive reinforcement for reporting bullying behavior and unkind behavior by other children, and making sure to normalize the experience so that they don't feel isolated in this. That bullying happens to a lot of kids. There's a lot of unkind children or people who behave in unkind ways for a variety of reasons, and that it's really important to talk to somebody about that. So just reinforcing the communication on that. So those for those, 7 causes associated with abdominal pain and the start of school are relatively easy to treat, as we mentioned. And so if those occur and you provide a plan for assessment and treatment, I would give them 2 weeks. And we would take the step down here. So they have a history consistent with constipation, lactose intolerance, etc. Yes. If we modify in a way that we discussed, either treating constipation, avoiding lactose, etc., we follow up in 2 to 4 weeks. If there is improvement, yes, then we've found the solution and our problem is solved. If in 2 to 4 weeks after making an intervention, the symptoms persist, then we need to follow the arrow to the left here, and we need to start evaluating for organic causes of GI upset or abdominal pain for the reasons that I discussed earlier. So sort of the standard first step in workup for those kids would be to get a CBC with differential, a complete metabolic count, a TTG IgA, and a total IgA to look for celiac disease, lipase to look for evidence of pancreatitis, a TSH, and then I apologize that I can't believe I didn't put this on here, but I would also get an ESR, erythrocyte sedimentation rate, and a CRP to look for evidence of inflammation. Excuse me. And so those are the sort of general screening labs that I would do for somebody at that point. If they are abnormal, so if they are not normal, then they need to be referred to the appropriate specialist. If there's an elevated inflammatory marker, a high TTG IgA, anemia, then they need to go to GI. If they're or lipase, if their thyroid hormone is low, they go to endocrine, etc. If those are all normal, then I would find out whether they have any lower GI symptoms. So any lower abdominal pain, bloating, cramping, diarrhea. If that is the case, then I would get a stool calprotectin. So stool calprotectin is a really useful screen for GI-specific inflammation. Calprotectin is produced by neutrophils. And so it is, if there is inflammation in the GI tract, be it from an inflammatory condition such as IBD or infection, it's going to be elevated. If that calprotectin is not normal, then they should be referred to GI. If the calprotectin is normal, then they fall into this yellow bubble area of functional abdominal pain. So functional abdominal pain, just briefly, because this is a topic that is so complicated and there's so many variations and types of functional abdominal pain. It could take about a year to talk about. But functional abdominal pain essentially is pain lasting at least weekly, pain happening at least for 2 months, happening at least weekly. It may be associated with other pains such as headache and fatigue and anxiety. It doesn't have to happen in isolation. And there are none of those red flags that I mentioned before. So no blood in the stool, no weight loss, no nighttime bowel movements. Management in brief is really to validate and reassure patients, that the symptoms are real. We're not doubting that they're having them, but they're not dangerous. We try to reassure them, give a lot of education, And it's really, really important to get them to get back to their activities, their baseline activities, as soon as possible. Some ways of sort of talking about this that can be helpful are using the term visceral hypersensitivity or visceral sensation, which basically, I think, sums things up in a way that's very digestible to most people. And basically, it's that the GI tract or the viscera are extra sensitive. And so things that are normal occurrences in your body, so moving of food, um, passage of gas, that sort of a thing, are felt very intensely. And that can happen for a variety of reasons. And when that happens, it's called visceral hypersensitivity. So you're feeling the normal actions of your body in a very um, extreme way, and it's leading to discomfort and pain, but there's actually nothing physically that's happening improperly, or at least as much as we understand at this point. For functional abdominal pain, in general, there's no empiric recommendations for pharmacotherapy. Down here, I've this review by Rex Winkle was just published in Pediatrics in this year, and it was a review that looked at pharmacotherapy for functional abdominal pain in children, and really there's nothing that is really, you know, has a good outcome in terms of efficacy. But what they do say is that it is safe to consider antispasmodics and/or antidepressants, given that there are some favorable treatment outcomes and a lack of significant side effects. If you are particularly interested in functional GI disorders or want to learn more, I've highlighted in fuchsia here this article by Jeff Himes, um, Childhood Functional Gastrointestinal Orders in Gastroenterology from 2016. This is an outstanding, very clear overview of the various kinds of functional abdominal pain that children experience, and with some very good um, treatment regimens for each of those. This is just a schematic from Dr. Himes's article that I mentioned, and it just sort of gives you a very brief overview of how this functional abdominal pain, visceral hypersensitivity can occur. And essentially, there are stressors of some kind. There's altered GI physiology, changes in the microbiome, a flu, an episode of constipation, food poisoning, and then psychosocial stressors that coupled with either risk factors, which are, can be early life events such as um, uh, issues with colic or um, reflux, pain early in life, or protective factors such as a supportive environment, um, lack of pain in the past, and then the response, either maladaptive or accommodating, really um, gives this trajectory of whether this is going to become a chronic pain and a disabling functional abdominal pain, or if the patient's going to be able to develop normally and really develop some coping mechanisms that allow them to function well in the setting of this pain. So a very complicated process, which is really being evaluated quite heavily right now. Um, but that's a very brief overview of it. So I hope that this was helpful. I hope everybody has a very smooth and happy return to school. Um, this is my contact information. So if anyone has any questions or follow up, I'm happy to help out in any way that I can. Thank you.